The story of Cinderella, the prototypical persecuted heroine, has been around for millennia. In 7 BC, it was Rhodopis, a Greek slave girl who marries the king of Egypt. In 860, a Chinese version stars Yi Shen, a hard-working girl who befriends a fish, or something. And a slipper's involved, I think. And then one of the most popular versions was written in French by Charles Perrault in 1967 under the name Cendrillon. That's when the whole fairy godmother pumpkin royal ball glass slipper subplot was added. There's a theme that runs through all these stories. At the end of the day, Cinderella ends up with that princess hat. It's time to add yet another subplot to this timeless fairy tale, because it's sketchy. A cone-shaped princess hat is our recurring symbol for the aortic valve. And just like that mitral valve, it can get stenosed, or it can get all regurgy and stuff. Let's start with stenosis. Aortic stenosis is, by far, the most common lesion affecting the aortic valve. It typically affects patients in the 6th to 8th decades of life. So, in this scene, the disease process will be embodied by the elderly crotchety stepmother, putting some serious stenosis on that aortic princess hat. What's her backstory, though? I mean, was she always this crusty? And what is that on her face? Well, it turns out that in North America and Europe, the most common cause of aortic stenosis is calcific degeneration of the aortic valve leaflets. Hence the calcium milk mustache on her upper lip. Her upper leaflet, if you will. Leaf lip. Get it? Yeah, you get it. Less common causes include valve damage from endocarditis, metabolic diseases, systemic lupus erythematosus. But for all intents and purposes, calcification should be the first thing that comes to mind when considering aortic stenosis. Dystrophic calcification of the valve leaflets involves endothelial and fibroblast cell death secondary to chronic hemodynamic stress or atherosclerotic inflammation. Yeah, I said cell death. Just take a look. This cranky mistress kills everything she touches, including dreams. See how that aortic valve is getting all necrotic? Calcification is one of the hallmarks of cell injury and death, left behind after any kind of tissue necrosis. So this is not just some kind of benign calcium crust forming here. This valve is undergoing permanent damage. It was once thought that calcification was just a normal finding caused by wear and tear on an aging valve. However, it's becoming increasingly more accepted that the underlying mechanism involves the same kind of vessel damage that causes atherosclerosis. So the same risk factors likely apply here, including hypertension, hyperlipidemia, diabetes, inflammation, all the stuff related to the progression of atherosclerosis. Notice that the red, gunky candle there looks just like an artery overflowing with atherosclerotic plaques. Histologically, dystrophic calcium shows up on valves as fine, gritty white clumps. See? Kinda crunchy looking. Stenosis will progress asymptomatically for years, but once it starts to cause symptoms of outflow obstruction, prompt valve replacement surgery is a must. This stage is usually reached in the 6th to 8th decades of life, unless you have a bicuspid aortic valve. Take a look at the mouth of Cinderella's horse puppet, strewn on the ground. The nose and lower lip kinda open to form 2 cusps. See? Well, the aortic valve is normally composed of 3 cusps, but in about 1 to 2% of live births, an anomaly leads to right and left cusp fusion. So you're left with only 2. And trust me on this, it looks just like the mouth of a hand puppet. So instead of the shear stress being divided between 3 leaflets, 2 cusps must bear the brunt of all that hemodynamic stress. This, coupled with the other risk factors for atherosclerosis, means that dystrophic calcification progresses even more rapidly. Hence the calcium-rich milk spill. These patients will require valve replacement 10 to 15 years earlier than patients with normal valves, sometimes before the age of 50. So, aortic stenosis? Pfft, what's the big deal? The heart just has to pump a little harder, right? Well, yeah, for a while. See that conch shell headdress she's got going on there? At Sketchy, a conch shell like this is our recurring theme used to convey concentric hypertrophy. Instead of concentric, think conch-centric. When a ventricle is chronically pressure overloaded, like when it has to pump against a tiny stenotic aortic valve, The myocardium gets buffer by adding sarcomeres in parallel, like the concentric layers of that spiraling conch. This helps the heart preserve stroke volume and maintain cardiac output. Look for that hypertrophied left ventricle on echocardiogram. The normal cross-sectional area of the aortic valve is about 2 to 4 centimeters. An area of less than 1.5 centimeters is considered moderate stenosis. Less than 1 centimeter is severe, and less than 0.5 centimeters, now we've reached critical stenosis. In general, patients with normal systolic function rarely show symptoms until aortic stenosis is severe, and even then, some patients will remain asymptomatic. However, eventually the heart just can't take the pressure, and just like we illustrated in our heart failure sketch, that concentrically hypertrophied wall causes diastolic filling problems and a diastolic heart failure. So sad. Now she'll never get to go to the ball. As we've seen throughout this course, almost any time the left ventricle sees higher filling pressures, it gets translated to the left atrium. This can lead to left atrial enlargement and hypertrophy, which is depicted by the dilated upper left wing of our fairy godmother here, who's come to save the day. Who's come to save the... Looks like she's struggling a bit there. Yeah, a dilated atrium doesn't like to conduct properly, remember? So say hello to atrial fibrillation. Let the irregularly irregular signal coming from that wand remind you of the irregularly irregular heartbeat characteristic of AFib. As we'll see in a second, even a simple arrhythmia can cause the patient to crash. Let's illustrate the 3 classic clinical manifestations of aortic stenosis: heart failure, syncope, and angina. Heart failure usually presents as dyspnea on exertion or decreased exercise tolerance. Aw, look, Cinderella's mice friends are rushing to her aid. That one in the back, though. Definitely some exercise intolerance going on. There's another process going on here as well. Aortic stenosis patients have what's called a fixed cardiac output. Because of the stenotic valve, they're unable to increase cardiac output during times of exertion. Imagine this dim, heart-shaped flashlight here, just unable to boost its output any further, even in a time of emergency. This fixed cardiac output problem is also one of the reasons patients with aortic stenosis develop symptoms of angina. They're unable to increase cardiac output and supply the heart during times of exertion. Notice that we've sketched in our recurring angina anvil, evoking that characteristic chest pain and pressure. Angina also develops because that massively hypertrophied myocardium has a higher myocardial oxygen demand. And because of the hypertrophy, it becomes harder for the coronaries to perfuse the subendocardium. And finally, there's syncope. This we tried to convey by making the anvil sink into the ground. That sinking syncope feeling. Remember that these patients have a fixed cardiac output, so when they stand or exercise, the heart is unable to generate a compensatory increase in cardiac output to meet the new demands of the body. This includes the brain. Decreased perfusion to the brain will cause syncope. I want to bring your attention back to that atrial fibrillation wand as well, because even a simple arrhythmia like AFib can be devastating. Atrial fibrillation causes a loss of that atrial kick, which leads to as much as a 40% drop in diastolic filling volume. Well, that ventricle is already working as hard as it can to get blood past that stenosis, so even a small decrease in preload can cause a precipitous drop in cardiac output. This is why it's so important to avoid arrhythmias and tachycardia. Well, this story is really taking a turn for the worst. And to top it all off, we've drawn in the murmur lines of her harsh, pathetic sobs. The murmur of aortic stenosis is a unique one. On auscultation, it will sound like a harsh crescendo-decrescendo systolic ejection murmur at the right sternal border. It's called crescendo-decrescendo because the murmur gets louder as pressure and flow increase during contraction. Then it gets quieter and disappears as the aortic valve closes. And remember, at Sketchy, whenever we want to convey an event that occurs during systole, look for that systolic spray. This time, a systolic spray of tears. As her cries echo through that fireplace, keep in mind that the murmur can sometimes be heard radiating to the carotids as well. And remember how hypertrophied that left ventricle is? Well, it's no surprise then that you might hear an S4 gallop right before that S1. This occurs when blood comes into contact with that stiff, hypertrophied, non-compliant ventricular wall. At Sketchy, S4 is embodied by a stiff wooden chair, shaped like the number 4. Now, some of these physical exam findings actually help us determine the severity of disease. We'll illustrate them up above the fireplace. Take a look. It's the evil stepmom's newest inspirational poster. Really just there to remind Cinderella that if she's ever caught being late to her post, she'll be punished. Tardis and parvis describe the carotid pulse. Because blood from the heart is impeded by that stenotic valve, the carotid pulse will be delayed, or tardis, and weak, or parvis. Both are a sign of severe stenosis. Recall that the systolic murmur is described as crescendo-decrescendo. Well, it turns out that the timing of the crescendo peak can help us determine the severity of stenosis as well. A later peak means a worse stenosis. And as you can tell by this photo from Cinderella's youth, she definitely peaked later in life. Just a late bloomer is all I'm saying. And finally, a diminished